and get started.
Okay, so first, just for a quick mic check, can you hear me, Casey? Am I coming through?
You're
No
good.
echo. Good. Well, Casey, thank you for that very generous introduction. It's a pleasure to speak with everyone today about lateral and medial epicondylitis, aka tennis elbow and golfer's elbow. And I want to make this discussion a discussion if possible. I think it's more worthwhile in that way. So I'm going to try to limit my talk in the first part to just kind of a general overview of some of the basic aspects of these two diagnoses, and that hopefully will spur some discussion that we can then have in the Q&A. I think, again, that's really where it's most helpful. And I want to make sure that I'm not talking too far above or below folks. So you can give feedback to Casey as we go. And as she mentioned, we'll do some Q&A to follow. So a little bit about me, as Casey mentioned, this is my a little bit of my kind of responsibilities. I am an orthopedic surgeon. I specialize in hand and upper extremity surgery, as well as orthopedic trauma surgery. I hold a few responsibilities here at Rothman as our upper extremity fellowship program director. I'm a professor at Jefferson Med, and I'm also most recently an associate dean and professor at Drexel Med as well. One of the more fun parts of what I get to do is that I find that people get a kick out of is to take care of a lot of our high-end athletes and our professional sports that we take care of, as well as some of our collegiate institutions that we are lucky to have nearby. So let's get into it a little bit. So let's talk a little bit about epicondylitis and just get the basic lingo down. So lateral epicondylitis, lateral means on the outside. So if you put your hands out, up, the outside part is the outside part, we call it lateral. The inside part is the inside part, we call that medial. So lateral epicondylitis, and medial epicondylitis, or aka again, tennis elbow or golfer's elbow. And frankly, I find those terms a little bit silly because folks often feel like they have to play those two sports to get those problems of epicondylitis or to get those diagnoses. And that's generally not the case. I find it actually pretty infrequent that people get it from tennis and golf. They mostly get tennis elbow and golfer's elbow from everyday activities that causes strain and or injuries to the inside or outside part of their elbows, and we'll talk a little bit more about that. But it can be quite debilitating, and it is very much a nuisance-y thing, and it can limit your ability to do really everyday kind of activities such as, lifting a bag, lifting a plate of food, opening a door, and lifting things off the ground. It can be quite limiting when it's really, really angry. So let's talk a little bit about it. So broadly, when we think about lateral epicondylitis, it's a strain or tendonitis of the extensor tendons of your wrist and forearm. So the tendons that start at the tip of your elbow, go across your forearms into your wrist, and their job is to extend the wrist, right? So if you have any kind of repetitive extension moment or a singular significant strain on that, you can then strain the tendons, and then its origin, which is the epicondyle, which is on the tip of the humerus, and then can cause that. So it can happen repetitively in the concept of being in tennis with the repetitive backhand motion. That backhand motion repetitively puts strain on your extensor tendon. Or it could be some singular event that was a little bit too much and put your arm in an awkward position it's not used to, or strained to a level it's not used to, and now it hurts. Switching gears, and I'm going to do a lot of parallel conversations between golfers and tennis elbow. And a lot of the treatment's kind of the same, but some of the distinction early on I'm going to try to emphasize, but do it in a comparative manner. So golfer's elbow is on the inside part of the elbow. So that's usually from, again, either repetitive or resisted wrist flexion. So a common thing is swinging something. So actually a forehand in tennis can cause it, a swinging a baseball bat can cause it, and the big one is golf. And it could be repetitively in golf, or more commonly, sometimes someone might have what we call a fat swing, where you take too much earth, if you will, and that puts a lot of strain on the inside part of your elbow as you're stabilizing your wrist, and that can strain the tendon as well. And that's where kind of the terms originate, and that's what it kind of represents. And when you present with it, when you start to have these, what you'll notice is pain over the tip of the elbow, so lateral on the outside part of the elbow, golfers on the inside part of the elbow. And then with lateral pain with the resisted wrist extension, So if you take something, you try to extend it and hold it up like this, it causes pain. And vice versa with flexion, with golfer's elbows on the inside part of the elbow, and then resisted flexion can also cause pain in the area. And that's part of the way that we also kind of test for it, which I'll show you a little bit in some of the pictures I'm about to show you. But that's what it is. But, that's when we isolate them. But broadly, when you're suffering from them, it just can be broadly that the outside or the inside part of your elbow hurts and you feel a weakness. Like you might say, like, I don't have the strength to do that anymore. Because the pain will then limit how much force you're willing to place on across that tendon. And that creates a sense of weakness. But really, pain and strength are inverse. So when pain is high, strength is low. When pain is low, strength comes back a little bit. But you'll feel that pain and a sense of weakness when you have this problem. So what's going on anatomically? So if you look in terms of the anatomy, the elbow is made up of three bones that come together. The humerus, which is the big one up top, the radius, and then the ulna on the bottom part. So radius is on the lateral part, ulna is on the medial part. And the epicondylitis is when the tendons originate on the epicondyles of each bone, which are the 2 points that you feel on your bone. So that's actually the distal humerus, has 2 pointy areas. And that's where the tendons originate from. And that's when they're inflamed. That tendon is kind of the weak link. And that's the spot that tends to cause pain. That's where it loads. And that's where you feel inflammation. So that's where, if you look at these pictures, you'll notice kind of where they tend to. I'm putting my arrow on the area. So for here, you'll see how it's kind of sore on the inside part of these, if you will. So let's get into a little bit of the treatment for this, just to talk a little bit about what you can do early on before you have to even see anyone for it. Because a lot of times this goes away, right? So not every case of epicondylitis, be it lateral, medial, needs treatment for it. And sometimes it's first of all recognizing that, hey, I think I strained my elbow here, my epicondyles, they're sore. So one is what we call activity modification, which is a fancy way of saying if it hurts, don't do it, or do it in a different way. So for example, like, with lateral epicondylitis, it hurts to lift things palm up. So don't lift your bags or your purse palm up, palm down, lift them palm up instead. Just lifting them palm up instead of palm down alone takes that strain off that area. Similarly, with golfer's elbow, you can switch the order. It hurts to lift palm up, so lift to palm down. So there's a little bit of modification, or avoid altogether, if you can, the thing that tends to aggravate it for a period of time until it starts to feel better. Stretching is another important one. So the picture up here shows someone stretching their lateral epicondyle tendons. And if you simply just Google tennis elbow or golfer's elbow stretching, many excellent videos come up in terms of how to stretch your elbow, forearm, and wrist out. And they're very easy stretches to do, like a series of 2 or 3 different maneuvers to stretch them out. And they do quite well. So first, you're avoiding some of the strain from the activities that cause it or aggravate it. Now you're doing a little bit of stretching as well. The third thing you can do is try a brace. So the picture on the right is a tennis elbow or golfer's elbow strap. You can get these in the drugstore, sports store, or Amazon for $10 to $15. And the point of this is that it sits on the highest part of the muscle on the outer or inner part of your forearm. So the outer part's your lateral epicondyle, your lateral epicondylitis muscles. And what it does is kind of put some pressure on the muscle so it doesn't achieve full maximal excursion, and that thereby offloads the pull on the epicondyle at the elbow. So it's also known as a counter force brace, but you can look online as just a tennis elbow or a golfer's elbow strap. Simple, cheap, easy thing to do. What I like about it is that it doesn't get in the way. You can wear it on your clothing, doesn't block your elbow and wrist motion, pretty low profile. And if you have a mild case of it, or if you tend to have this problem specifically with a certain activity, like when you play a certain sport or lift weights, that's a nice thing to use when you're doing those exercises or activities to minimize the stress on those elbow tendons. And the other thing you can do is also take some NSAIDs. And so it's short for non-steroidal anti-inflammatory drugs. These are very large, common class of medications that we use routinely, like Motrin, Advil, Aleve. Those kind of medications online are really helpful for this. And I find that when it's really flared up, you want to take it on a consistent basis for a while rather than just kind of as needed, and have a cumulative ongoing effect to help decrease the soreness. Some people also ask about ice and heat. Both are fine. I always tell people whichever one of the two works better for you. I think in the acute period is good. Generally, we do ice for kind of acute injuries and heat for chronic problems. But again, I think either is fine based on what you think works best for you. So these are things that you can do on your own before you necessarily have to, see anyone for it, because a lot of these issues with epicondylitis, be it medial or lateral, can get better with just some of these type of intervention that you can do on your own simply enough. So let's keep going. So let's say now it's still really hurting you. It's not getting better. We're going on weeks, maybe months. It's not improving. Well, then it's reasonable to see someone forward. And here at Rothman, as well as other places, folks are very well equipped to manage this. We have many physicians, both in my service, which is hand and upper extremity, the sports service, the shoulder elbow service, etc., who can manage this diagnosis. It's a very straightforward diagnosis and one for easy one for us to manage. And what a doctor is going to do when they see you for this in the beginning is they're going to, take a look at your arm. They're going to see if there's any kind of deformity or swelling or anything out of the ordinary. They're going to arrange your arm to make sure there's anything out of the ordinary in the elbow joint or forearm. And then they're going to put a little bit of pressure, and they're going to palpate right over the epicondyle. So here's a picture of lateral epicondylitis evaluation, where they'll kind of put pressure right over the lateral epicondyle, and they'll see if it hurts or not. And that's like a really easy way to see if that's the problem or not. And then the other thing they'll do is they'll kind of have you extend your wrist against some resistance and see if you're able to do that. Those are two really easy ways to diagnose it on exam, and they tend to be pretty consistent when people have tennis elbow or lateral epicondylitis. And then the flip of that with golfer's elbow is pretty convincing on exam. Other things we look at, are there other things that may be causing your symptoms, such as instability of the elbow? Sometimes when people have lateral and medial collateral ligament insufficiency or weakness or laxity, they can examine like an epicondylitis. Some folks who have nerve problems, so radial tunnel syndrome is something we think about when someone has tennis elbow, and cubital tunnel syndrome is something we think about when someone has golfer's elbow. Again, we're pretty good at being able to discern and kind of tease out the difference, but there are two diagnoses that are high on our differential when we're considering someone with lateral and medial elbow pain. But just so you kind of know what to expect when you come in. Another big question people have is, should I get some imaging? Do I need an X-ray? Do I need an MRI? And to be frank, you really don't need any imaging to absolutely make the diagnosis. It comes in handy in a few capacities. X-rays are helpful just to make sure that there's nothing in the setting of trauma, that nothing abnormal is going on, like a fracture or a dislocation or degenerative process. But generally, in someone who's not had any injury, it doesn't offer a ton. Occasionally, like in this case, you'll see some calcification on the lateral aspect of the elbow that is a sign of chronic lateral epicondylitis, but you can make the diagnosis even without that. The big question I probably get in the office is, don't I need to get an MRI? And the answer is not really. The MRI is not necessary to make the diagnosis. Like I said, making the diagnosis itself is relatively straightforward on history and exam. The MRI does come in handy if we're trying to determine which treatment strategy to do, i.e., can we continue with non-surgical treatment, or do we need to think about a surgical intervention for the diagnosis of lateral epicondylitis? And I'm going to just pause and say here that the far majority of tennis elbow and golfer's elbow, or lateral epicondylitis or medial epicondylitis, can be treated non-surgically. The majority do not need any kind of surgery. Occasionally do in someone who has like persistent or chronic or recalcitrant epicondylitis, and we'll look at surgical options. And surgery works quite well when that happens. But I just want to stress, because I think oftentimes people feel like they have to have an MRI. MRIs take time, and it's an inconvenience, and there's cost to it, and it's not always routinely necessary. It's more for most of us, particularly from a surgical perspective, we need to change course. If you do end up getting an MRI, you'll see a lot of terms thrown around on your reports which scare patients. You'll hear things like tendonitis, tendinosis, interstitial tear, partial tear, complete tear, retracted tear, lots of different ways to describe the tendon. And I would tell you the first four, tendonitis, tendinosis, interstitial tear, partial tear, you might hear articular tear, etc., they're pretty common, and they are pretty normal for lateral or medial epicondylitis. And they're not alarming by any means. And the problem is the term tear is a very non-specific term. It's like saying fracture. It's like saying accident. You don't know what it is. It's unqualified. So an accident means that you could have stubbed your toe, or an accident means you fell off a building. They're both accidents, but they're all obviously both very different injuries. So they're not all qualified. So tears are the same thing. It's not always something that's a bad thing, and definitely not something that always needs surgery. They can often be chronic tears or wear and tears or heal themselves, just depends. But you're going to see these terms. I'm just putting them in front of you so that you're not alarmed if you end up getting an MRI and seeing this. As surgeons, we often the patients are often treated elsewhere, and then when they have persistent symptoms and their providers or doctors get an MRI, they'll see these. They'll send them to us for surgical consultation. And sometimes they do need surgery, and sometimes they don't. It just kind of depends more globally, not the fact that there's simply a tear on the MRI, but more globally based on kind of how the patient's doing, how long it's been going on for, what they've done so far, are they getting better or not, what are their limitations, if you will. So what do we do? So let's say you come see us for this. Are we always going to do surgery for this and what have you? No, we'll probably do some of the initial treatments that I mentioned to you as well, and maybe a little bit more. So again, we'll talk to you about activity modification. We'll talk to you about using a brace. We'll talk to you about stretching. Now we can start to prescribe some things too, since you're seeing a provider. One thing is to prescribe physical therapy. Physical therapy is really useful for different diagnoses. I find for epicondylitis, it can be quite helpful. For certain diagnoses, it's less helpful, but for epicondylitis, I think physical therapy can be quite helpful, and that's something that we'll offer our patients if they have some epicondylitis. The other thing are NSAIDs. So we already talked about Advil, Motrin, Aleve. There are stronger medications we can prescribe as well, and sometimes the stronger medications are helpful also. And the next thing, probably the next big one, are cortisone shots. Cortisone is kind of a catch-all term for an injection of a corticosteroid. Corticosteroid is the official kind of term that we ought to use, but we usually use the term cortisone. And they're basically a steroid, literally, that's being injected into the origin of the tendon. And its job is strictly to be an anti-inflammatory. There's various types of steroids. Common ones you hear are like Kenalog or triamcinolone, betamethasone, dexamethasone, and they're relatively low volume medications, and they're meant to be an anti-inflammatory to help cool that area down so that it can start to recover and feel better. We use injections very regularly. People have very, very differing opinions on cortisone. I'm always impressed by how many opinions people have on cortisone, and I'm always unclear where they came from. But broadly, if you're getting the injections at a appropriate dose at long intervals, they're fine. A lot of folks assume that you can only get one or two. There's some arbitrary fixed number. I always tell patients it's more about the frequency and the response to the injection. If you get a shot and you don't get a response, or adequate response, is probably not working for you. If you do get a shot and it wears off very quickly, that's probably not going to work. But if you get a shot and your symptoms are gone, and say it recurs 3 or 4 years later, it's perfectly reasonable to just re-inject at that point. So it just kind of depends. So there's no absolute. There's a lot to consider. And at the end of the day, cortisone is just medication. So we're treating it like a medication, except that we're delivering it locally to the area where there's a problem. And I'll tell you, I find cortisone very, very helpful for patients. I would say in my own experience, 2/3 of people get 1 or 2 shots, and it will clear up the problem for them. So it's a pretty nice technique in terms of managing one's symptoms, but it doesn't always work, and doesn't mean it can't recur again if the stress and strain again has found its way to the tendon once more. So that's a little about injections, and I think there'll probably be questions about that later. We'll talk more about that. I also want to spend a little bit on PRP, because this is a hot topic nowadays. Platelet-rich plasma. Even today, I just finished up office hours. I had 3 or 4 people ask about this. A couple of things I know about PRP. First of all, I personally feel that PRP can be helpful in the right diagnosis in the right patient. It's not something that works for everyone and for every diagnosis. I think it really works well for like degenerative tears, like in the tennis elbow, golfer's elbow area, like in rotator cuffs, quadriceps tendon, patella tendon. I think they can be good. And the concept with it is basically they take your own blood, they centrifuge it down to concentrate into its different elements, and then they take the part that has the inflammatory cells, the blood cells that can help with healing, and they inject that back into the area where you're having your symptoms, so that you're giving some concentrated healing cells that are your own back in the area. And it can help. I will say to you that the science is a little bit mixed on it. Some studies show that it does really well. Some studies say it doesn't. You should also know that most insurances do not pay for it, so it's an out-of-pocket expense. So I always tell patients that I think it has promise in certain diagnoses. I'm relatively agnostic towards it. They have to understand that the data is mixed on it and that there is a cost to them. But I don't think it's an unreasonable thing to try. And it doesn't burn any bridges in terms of future surgeries or what have you. So if that's something people want to do, I don't think it's unreasonable to do. And we could talk more about that. So what do we do in the minority of cases? And this will be the last part we'll talk about. I'll open up to Q&A. I only want to talk for 20, 30 minutes. So what do we do in folks who have persistent symptoms? And occasionally they'll need surgery. And like I said, it's not the majority of folks with tennis elbow, it's the minority. But some folks just have a chronic tendonitis, partial tear, interstitial tear, etc., that just causes them constant pain and weakness. And they've tried the other stuff, and where they're going on months and months, it's not getting better. Surgery can absolutely treat this, and surgery is very, very effective for this. I just want to stress, though, for whoever's listening and watching, I have a couple intraoperative pictures. So if you're not comfortable with this, you may want to drop your screen and just listen to me, or turn away, or however you want to manage that. I just want to warn you, they're not horrible, at least not from my perspective, but I know everyone's different with looking at things inside the body. But basically what we're doing in tennis elbow is we're going to the tendon that's torn and then debriding it and or repairing it. So just to orient you, up top here is where the hand is, over here is the shoulder, this is the elbow, this is the tip of the elbow. This is the interval that we develop that is between the two tendons that we call the ECRL and the EDC tendon. And the deep to it is an important tendon that causes most folks with epicondylitis, called the ECRB tendon. And you can see here, that's what's torn. So this is just exposing, and you can see it just kind of pops right out. That's been chronically torn, and it's a very inflamed, causing local irritation. So that's one of the things we manage. This is another patient. Same problem. You'll see the interval between the ECRL and EDC is developed, and you'll see the pickups is picking up the retracted, torn, chronically torn ECRB tendon. It's no longer attached to the bone, attached to the humerus itself, and that's repaired. That's what's repaired. And again, here's one more. This is just a close-up of that. The tendon actually ends right about here where my pickups is, and this whole area is just inflammatory tissue. This is not tendon here. The tendon ends right there. You can see the fibers of the tendon, so they're not attached to the bone any longer. This is the area where the tear is. And similar patient, there's another patient where you can see a big hole where the tendon is. Even before we raised the interval between the EDC and ECRL, there was already a pretty big hole that involved the ECRL as well. These are the names of the tendons. And this too, we can see there's a hole right upon entry. And what we do is we debride that, repair that, and you can see we repair it and close down that area, repair it back down to bone. We're repairing the interval down and also tightening up the collateral ligament. And this works really nicely in terms of taking your symptoms away and helping that tendon to heal itself. So I'll step away from these gory pictures, and I think we can pause here. It's been talking for about a half hour, so I think this is a good spot for Q&A. Casey, I'm gonna hand it back to you if you want.
Yeah, great presentation, a lot of good information. So I appreciate that. One question which you did, well, let me just go there. Typically, how long does it take to get back to normal without surgery? You reviewed all those options, physical therapy, and said all that. How long typically without surgery?
Yeah, I mean, that's a common question, and one I can never really answer, because like any injury, it just kind of depends on the severity of it and like how bad of an epicondylitis it is, how long it's been going on for, how soon did you start treatment. So it's hard to say, but I do prepare people like it's not going to be gone in a day. It can take a few weeks. That's where shots come in helpful. Shots usually kick in within 2 days to 2 weeks of the injection. That's what I typically quote. Most folks are on the early end of that. So that's the one thing that I can do, that I can say with more reliability, irrespective of how long it's been going on for, that within a couple of days, a couple of weeks, you should start feeling better. Now, the wild card with shots always is, will you get completely better and will it come back again? We don't know that until we do it and just kind of see how you respond to it. Just like any medication, you have to trial it and see how it goes. But that probably has a more consistent. Without that, I mean, in terms of activity modification, bracing, therapy, stretching, NSAIDs, it can take a little bit of time. It can take weeks to get better.
Thank you. Next question. How can I prevent golfer's elbow from coming back, flaring up this year?
Yeah, if for those folks, I'm gonna just infer from that's happened before, and they're worried it can happen again. The key would be a few things so preventatively. I think is a great question. One is like identifying what your triggers are. So if you know what it is that tends to fire it up, then you want to be really careful with that. Let's just use the common example of golfing is triggering it, right? Let's assume that's the case. Then you got to be careful with your game a little bit. And I'm not a very good golfer, but I understand the game. You got to be careful. So, for example, like you want to make sure that you're warming up adequately. You're going to make sure that when you're swinging, you're avoiding fat swings, particularly with your irons where it's not teed up a bit. You want to avoid hitting in hazards, like avoid the rough. Avoid hitting in where there's branches. Avoid hitting sand. You may even tell your friends you're golfing with doctor's orders. I'm not supposed to hit in any hazards, because all those hazards put more strain on the inside part of your tendon. The other thing you can do is make sure that you're stretching adequately, and also that golfer's elbow strap that I showed you is really simple to wear. Does not get in the way. Does not prevent you from swinging your club in any way. All these little things are going to help, and I find that most folks who golf tell me that when they're really careful with their technique, they actually hit better. They hit straighter, and I think a lot of folks who golf, they tend to hit the ball pretty hard. And with more power, often comes less control, and with less power comes better control, and better mechanics is going to be key to avoiding recurrence.
Spoken like a true golfer.
Not me.
No. I know you showed a picture, but do you have any PT type exercise that would be helpful to prevent these conditions?
Yeah, so in PT, they're going to do a few things. So the one thing is to do it on your own. So like I mentioned earlier, is if you just Google, a search for tennis elbow, golfer's elbow exercises, plenty of stuff comes up, and they're good. And they're good because there's not that many and there's not that much to do. What you would do in therapy is a little bit different from that. They would incorporate the stretching that you would do on your own anyways, but what they would also do is add some what we call modalities, where they might do some ultrasound or iontophoresis in the area of the elbow to help kind of cool the swelling down. They may add graded resistance, where they'll give you different weights at different levels and different repetitions to kind of build up and condition with. And they also what's great about therapy is that kind of guides you on a regular basis to make sure you're not doing too much or too little. So they'll add the stretching, they'll add the strengthening, they'll add some modalities, and they'll add some guidance as well.
Someone asked a question about going into detail about evidence-based research on PRP, and can you discuss your RTP protocols post PRP injections? I don't know if you can do that off the top of your head.
Yeah, I mean, return to play protocols, it just depends. But generally, if for PRP, in terms of return to play, we generally are going to give it 2 to 6 weeks. And it depends what type of play we're talking about, the intensity level, whether the area that's being injected, what is its correlation to the play that you're going to do, for example, right? So it just depends. But generally, you're looking at in the range of 2 to 6 weeks, and often closer to 6, because broadly you got to give the medication, the PRP, some time to work. For surgical repair, our return to play typically is closer to 12 weeks, because we want to make sure that the repair is adequately strong to resist forces. So we typically recommend 12, although you're pretty good at 4 to 6 weeks in terms of motion and range. To get the strength back and to feel and to be confident the repair is adequate, we're looking at 12. So it kind of depends. For PRP, I would say 6-ish, and for surgical repair, about 12-ish. In terms of the evidence, like I mentioned previously, the evidence is kind of mixed. There's lots of papers on them. The problem is, the different centrifuging techniques are different. Every PRP's condensate the concentration of the cells that you have now obtained, they're variable in their immune cells in there. They're not standardized. They're not like a Tylenol over the counter that says 500 milligrams. You know you're getting 500 milligrams. When you take your own blood and spin it down, we're not really taking any measurements of it. We're just spinning it down, taking the good cells and put it there. So our concentrations vary a lot as well. And then the structure you're injecting is not all the same. Some are just inflamed, some are partially torn, some are fully torn, some are fully retracted. So the problem with all these studies is you're doing kind of apples to oranges comparisons where both the quality of the tear and then the quality of the PRP are the two variables that you can't control for. So therefore, the scientific evidence is compromised by that. The more controlled a study is, the better you can rely on the data. The less controlled the variables are, the less. So I broadly think it has promise. I think it works in select folks, and that's why I'm not opposed to it. I tell people I'm agnostic about it, but I want to be very clear from a scientific perspective that there's a lot of variability in our understanding of it.
Thank you. Even though, sorry, is Tommy John surgery a frequent surgery you see, and typically how long is the recovery time for it?
Tommy John surgery is entirely different from this. That's a ligament tear. So that is a tear of the ulnar collateral ligament, also known as a medial collateral ligament of the elbow. It's not golfer's elbow. That's more of what we've been discussing, tendonitis. And the recovery for Tommy John surgery is when you actually reconstruct. So you take a graft from either a cadaver or another part of your body and place it there to restore the ligament. And you have to give it time to heal and then rehab. So it's quite a long recovery, particularly if you're going to be pitching in the range of 6+ months. And we definitely see we have some world-class surgeons who are like leaders in the world in Tommy John surgery, but it's not a gimme, surgery and recovery. It does take a lot of time, and 6 months might be on the early end, depending on what the throwing responsibilities of the athlete is.
Thank you. Next question. Even though the corticosteroid can reduce pain and inflammation, is there a higher risk of worsening tear instability in the tendon over time?
There's always a risk of that. And then the question often comes is the injection increasing that risk? And broadly, I would say is that if you're getting high dosages in short intervals, I would say yes. But if you're doing, 1 or 2 shots at the standard kind of low dosages that we use, the benefits outweigh the risks.
Right. Next question. Is there risk of additional damage if condition persists longer than term, like 2 years or more?
Yes and no. The problem can definitely worsen with time. I would agree with that. But if it comes to surgery, it doesn't actually make a whole lot of difference. So if someone has a bad tennis elbow or golfer's elbow for 6 months versus 2 or 3 years, the surgical outcomes actually, interestingly, are not different because the way we do the repair, it actually doesn't make a whole lot of difference. So a lot of surgeries we do, for example, I do a lot of fracture and nerve surgery. Those definitely are time dependent in terms of how people do in their recovery, particularly nerve surgery. But interestingly, with a tendonitis type of problem like this, if we do the surgery now or later, it actually doesn't make a difference. So that's why you'll find a lot of your surgeons are kind of more relaxed about it and let you kind of dictate timing for surgery.
Thanks. Does KT tape help with the pain and or healing?
I think KT tape is a pretty cool taping concept. I'm for it. I wouldn't use the language that it's helping with the healing or not because it's external. What it does, it can kind of offload some of your joint mechanics, limit you in certain extremes, limit your tendon excursions in certain extremes. So admittedly, I don't use it myself. Therapists do. I think it's pretty neat. I don't think it's like a silver bullet by any stretch, but I think it does help some folks.
Okay. Along the same lines, can you share the brace for golfer's elbow again?
Again, it's the same brace for if you just type in Amazon or Google, top right here, golfer's elbow or tennis elbow brace that comes right up. And it's actually the same brace that they just have you applied to either the inside or the outside part of the forearm. And it's the upper part of the forearm, the widest part of your forearm.
Okay. If inflammation is part of the healing process, do steroid injections mitigate or help an individual with tendinitis?
What steroid injections are doing is they're taking away some of the inflammation, which is causing the pain. So it's true that you need some inflammation. The body is going to have inflammation when you have an injury, but it also is the origin of the pain. So again, it's always a cost benefit analysis. And I don't think people need a cortisone shot the moment they develop tennis elbow. It's usually more when folks have kind of failed the other interventions, and or it's getting worse and more painful. That's when we'll start with a shot. That's why if you look at this list, it's lower down on the list. We don't start with shots necessarily, but if you've exhausted some of the other stuff, or they're not responding to it, or it's getting really bad, the shots can take the inflammation down so it hurts a little less.
Yeah. If someone had a cortisone shot for tennis elbow and it only lasted 6 weeks, should she give another one a try or get an MRI to see if something else is going on?
Yeah, both are fine. I think it's not unreasonable to give a shot 1 or 2 tries to see if it works. I think one shot alone not working, I don't think means it's never going to work. But I think 2 shots to me is generally, then I'm pretty confident that that person is not going to respond to a cortisone shot. And then ultimately MRI, like I mentioned, in my hands, and I should preface you by saying I'm sure a lot of docs get MRIs right away. For me, it's really about whether we're considering surgery, and that will then help confirm the diagnosis and then help to characterize the extent of the changes to the tendon so I can better counsel the patient in terms of what surgery looks like and recovery looks like.
Great. Do you have any do's or don'ts for over 50 pickleball players, for over 50 years or older pickleball players to prevent injury?
Do's or don'ts? Wow. I mean, broadly, I've played it a couple times myself, so I'm by no means an authority on it. But I'm a year from 50, and I play a lot of racket sports. What I see with pickleball was what I see with other racket sports is what I'm not seeing is much pain in the extremities because the racket is pretty light and the ball is super light. So that's what's beautiful about it. What I have seen with pickleball are people falling because the court is tacky. It's a tennis court, so it's very tacky. So people's feet get caught on it and they fall. So I see a lot of upper extremity injuries. I know there's also a lot of lower extremity injuries from the fall itself. I'm happy to say that I'm not seeing a ton of folks having pain from it, but obviously it's all about overuse. So if you're overdoing it, and you're going to put yourself at some risk. So you always have to be honest with yourself, and always think of pain as a way that your body is talking to you. It's expressing itself to you, saying that they like or don't like something. So you can't disregard it. So if you're having a little bit of soreness, a little bit of pain, it's important to interpret that and recognize that you don't want to double down on it, but you want to pull back a little bit.
Right. Someone asked if a recording will be sent out. Yes, I am recording this, so I will be sending out. It takes a few days between downloading and uploading. So give me a few days and I'll send it out to everybody. And just along that note, I do want to remind everybody, if you did want to do a follow-up or make an appointment with Dr. Ilyas, that number is 610 480-6584, 610-480-6584.
I just want to, Casey, if I could just stress again,
Sure.
and again, you don't feel the need to see me for this exclusively. That's not my point of doing this. There's at our practice, we have a lot of physicians and surgeons that manage tennis elbow, golfer's elbow, again, in the sports services, in the shoulder elbow services, and the hand and upper extremity services. So common diagnosis with really good docs who know how to manage it.
Thank you, Dr. Ilyas. A lot of great comments. Thank you so much. Great presentation. Another question, does Graston technique help?
I'm definitely familiar with Graston. I always have my reservations about Graston. I think it can be a little rough and painful for folks. my understanding, and I'm going to preface by saying I'm not as up to date on the therapy literature, but my understanding is that therapy literature is fairly positive towards Graston. So I'm not going to talk you out of it. I wouldn't do it post-operatively. That discussion I've had because that stress on the tendon can irritate the repair site. But pre-op or for tennis elbow, I would say I'm ambivalent about it.
Great. Two more questions. Is BioFreeze or any other pain relieving topical agent beneficial for tennis golfer's elbow?
I'm a fan of the topical agents. You'll see things such as BioFreeze, Aspir Cream, Salon Pos, even Icy Hot. Australian Dream is a new one I've recently learned about. I think they're pretty good. They're all basically topical agents that work in a different way. Some have lidocaine, some have menthol, some have camphor, and they're meant to just decrease the pain in that site. I think they're very safe. It's easy to just rub it in. It's relatively inexpensive. So I think it's a perfectly reasonable thing to try, particularly for a mild case.
Right. And last question, does swimming help or hurt recovery from golfer's elbow?
I would say neither. I think that if you have golfer's elbow, depending on the strokes you're doing, you might have some pain relative to swimming. It's not something we typically use to rehab golfer's elbow. So I would say neither for the most part. And some folks are bothered with their epicondylitis when swimming. Others don't feel anything. So I don't think I would use a for or against tennis elbow management or golfer's elbow management.
Great. One more question popped in. If tennis elbow persists, can it do damage?
Well, by its nature, it's a tendon injury and it's a spectrum from inflammation to strain to partial tear to a complete tear, etc. So it's a spectrum, and if it persists for long periods of time, we clinically infer that there's something going on with the tendon. So one of the clinical signs that we look at is how long it's been there. And if it's been there for a long time, that means it's basically beyond the capacity of it to kind of heal itself. And that's why we start to get a little more, we pursue more interventions. So we infer that by chronicity or the length it's been there, that it's probably worse. So yeah.
Just one more question. Do we have to keep the hand stretched or folded with tennis elbow while sleeping?
Got it. In case this will be our last question.
Yeah.
As I don't think it makes a difference broadly when the elbow is bent and then you stretch in the morning, you're stretching out the tendon, so that can hurt a little bit. And similarly, when your wrist is bent wrist is flexor or extended for a long time, then you go the opposite direction, it can hurt. So I don't typically limit folks how they sleep, but it is definitely true with any limb or tendon problem. When you're in bed for a long time in a certain position, then you start to move that tendon, it starts to hurt more. But I don't think it's causing it necessarily. It's causing your tennis elbow or golfer's elbow.
Great. This has been a wonderful presentation. I want to thank you for taking the time, and everybody who joined us tonight. Again, thank you for meeting us virtually, and I will send this presentation out in the next few days. So thank you again, Dr. Ilyas. I appreciate it.
My pleasure.
Thanks.